Good morning, good afternoon, wherever you are. Since we have an international audience, I want to welcome everybody. My name is Dr. Kogan. I'm a physician at the Center for Integrative Medicine at Stanford. My expertise is to work with cancer patients, do symptom management and stress management while they experience cancer. I often get referrals that say, can you please see this person? They have depression, they have anxiety, and that's the equivalent of telling an oncologist, can you please see this patient? They have cancer. So it's not enough information or not the best information to approach patients with cancer that are stressed out about their illness naturally. So the take-home message for today is that cancer is not a mental health disorder issue. It has to do with mental health, but it's not a mental health disorder. It has to do with distress. Why is that? When we look at cancer patients and compare them with normal people, the difference of what they're experiencing is very small or not there at all. This is a study that someone did comparing all the data that was available of people with cancer with healthy controls, and you see from the N that we're talking about 10,000s of people. So if you take depression in cancer patients, it's 11.6% compared to 10.2% in healthy people. So how is it helpful to tell me that someone has depression when they have cancer, when 1 out of 10 people in the normal population have that also? With anxiety, it's similar. There are a little more people that have anxiety when they have cancer, and that actually depends on when you're diagnosed. This slide shows this. On the left side is the risk you have to get depression as a cancer patient. And the number of 1 means it's like everybody else, but as you see in that first bar, in the first 2 years after a cancer diagnosis, that risk is higher. So if you're first diagnosed with cancer, you actually do have more depressive symptoms than the regular population. And the further out you get, it then becomes more a problem of anxiety. If you look at the bar on the right side, you notice that it's a little higher, close to 1.5, which means you have a slightly higher risk of having anxiety as a cancer patient when you're 2 to 10 years out. So the basic message is that we want to look at the stress rather than depression and anxiety. Again, you don't have to read the details. This comes from a paper by Carlson and her colleagues published in 2012. The important message is distress because it's clinically relevant. And let's look at distress in a cancer context. It defines distress as an unpleasant emotional experience of a cognitive, behavioral, emotional, social, and or spiritual nature, and it happens on a continuum. And that part is really important. You don't narrow people's experience into a label, a categorization. There's stigma attached to words like anxiety and depression. Distress is something that pretty much everybody has experienced in their lives. There are questionnaires we can use, and again, you are cancer care providers. If you're in a clinical setting, you don't need that, but if you're in a research setting, there's something that's called the distress thermometer. And the advantage is that you cast a much broader net. We're not just talking about mood, we're talking about the body, the emotions, practical aspects. Do you have enough money? So when we screen for distress, the disadvantage it has is that it has something that's called low positive predictive value. What that means is if someone says, no, I'm not distressed, you can trust that they're not distressed. If they say, oh, I'm incredibly distressed, you then have to further assess what this is about. It could, in fact, be depression or anxiety. Remember, 10% feel depressed and 17% do feel anxious. But it could simply be not being able to pay your medical bills. And then as a social worker, you can help much more effectively than if you get sent to a psychiatrist for medications. So again, back to that slide, this is the reason why I want you to focus on the stress rather than depression and anxiety. But let's look at anxiety. We do have a difference. So the longer the patients are out from their diagnosis, they do feel more anxious. And I just got this definition of Google. When you look at anxiety, what does the word imply? And you see a lot of the word nervous in there. So it has something to do with nerves. Most people look at anxiety as an emotion. I don't. I look at it as a physical state. Something happens inside your body when you feel anxious, and it's more nervous in nature than emotion. And that, in fact, is the reason why people feel more anxious, quotation marks, because they are more distressed. So let's look at those nerves. Imagine the brain as a central computer. Spaghetti come out, going to the periphery, innervating everything. Your muscles, you move your arm, you blink. Your body does that. And there's also a nervous system. You don't need to know the details of this. It's called autonomic nervous system that has a reflective response that most of you will know as fight and flight. So if someone feels stressed, and cancer is a stressor, then their nervous system will get activated in a way that they cannot differentiate simple threats like to fill out a bill and carry it to, or pay a bill and carry it to the post office from cancer. Their body responds to everything as being activated. They might flee or fight or freeze at anything. And that's the message I want you to take home. Think of the cancer patient as being in a nervous, activated state. Stress per se is not a bad thing. The title of the book by Robert Sapolsky says why zebras don't get ulcers. But the zebra on the right, unfortunately, does get ulcers while being stressed. And that's the part you need to know. We're not animals anymore running around in the jungle. We are now human creatures, but the nervous system that has that fight and flight response hasn't always caught up in its development to act appropriately. So let's look at the definition of stress. We talked about it in a cancer context when I told you that it's an uncomfortable feeling that I described in detail, but people without cancer have stress. And the one definition, again, Google is the common denominator for a lot of people, says it's a mental or emotional strain. You're tense, and it has something to do with adverse circumstances. Sounds like cancer to me. But as I said in the previous slide, cancer or stress is not necessarily a bad thing. It's simply how our body responds to something happening outside, something that has to do with change. So pause for a moment and think of a cancer patient as someone whose nervous system is activated because they have to respond to a threat outside of them. This curve demonstrates that, and this applies to everybody, also to healthy people. Stress is a good thing if you take it to a certain point. It makes you more productive. This is something people have found out many years ago. But if you are stressed too long, then you get fatigued, you burn out. And if that happens in the context of cancer, it's not good because you are in a situation where you need to make wise decisions. So you shouldn't be distressed. Distress affects your ability to make decisions. That's been shown. Your thinking gets foggy. If you're a patient watching, I'm sure you know that feeling. but as a provider, you also have experienced when you're stressed that you can't think as sharply. So let's look at Sarah. You watched the clip when she interacts with the doctor, because what I propose is shifting away from depression and anxiety, shifting towards stress and distress, the positive and the negative, and take advantage of the clue Sarah gives you in the movie and what to do about it to actually help her. I want you to pay attention to her thoughts. At one point, she's worried that she's disappointing her family. She talks more about her son and her husband than she talks about herself. I want you to pay attention to patient's emotions. She's really grouchy in the beginning. She's very short with the doctor. She's irritable, she's resentful, she's frustrated. And I was trying to read between the lines about what her body experiences. She states some things herself. She has this overall malaise. She has no energy. She can't focus. And she's exhausted. She can't sleep. So a lot of physical experiences. There is an interaction between Dr. Wilson and Sarah where Dr. Wilson says, "Sarah, do you think you are depressed?" Sarah says, "I think I have cancer." So going back to this slide, that's why I want you to look at what people say with respect to their thoughts, their emotions, and their body, because you can learn a lot. And this model has to do with a very old theory that how we respond to an external stressor. You can put yourself in this situation. Imagine a car, it's coming at you. You are the person on the right. You're thinking, you have emotions. You probably have a pounding heart. How does it feel when someone cuts you off in traffic? The problem is that all these things feed on each other. You might have the thought, oh my goodness, the car is going to run me over, which will evoke fearful emotions and probably a pounding heart. A pounding heart in reverse will affect your thinking. If you don't think, there's a good chance you won't sleep the next night or still think about it. So you end up having a stress response even without the car cutting you off. And the car stands really as a symbol for cancer. Dr. Wilson says, "Do you think you are depressed, Sarah?" And Sarah says, "I think I have cancer." And it's a very interesting part of the communication, because the doctor doesn't say, "Do you feel you are depressed?" She asks about her thought content, but really goes after a mood. And Sarah talks about the event, cancer. She doesn't even talk about her feelings. She talks about her husband's feelings and her son's feelings. So how we respond to a stressor, a car or cancer, very much depends on how we are inside, what all these things mean to us. And that's your hint. When you hear conversations, observe conversations, you can all use them to identify what the patient really needs. And that wasn't me that thought this theory up about analyzing thoughts, emotions. Those are all the smart guys that has something to do with it. I want to pay tribute to their very intelligent contributions to this concept. Let's go back to Sarah. So going forward, I want you to look at people with their thoughts, their emotions, and their body response. And I hope I've made a good case that from that information you can deduce more than when you ask someone, "Do you think you are depressed?" You could, or say, "Do you think you are anxious?" You could instead ask, "I'm trying to understand what you experience when you use the word depression or depressed." You know, Sarah doesn't think she is depressed. She says her husband thinks she is depressed. But what does it mean to her? She gives you mostly hints about physical problems or fears of disappointment. If you know that her biggest problem is pain or difficulty sleeping, you can specifically address that. You have a concrete problem to work on than getting stuck in a conversation where you say, do you think you're depressed? And the patient says, I think I have cancer. You can also say, what do you think your husband means when he says you are depressed? Maybe he's just fed up that she's constantly grouchy. It sounds like she's very competent. She likes to be in charge, run the show, and all of a sudden she's just a vegetable who can't do anything. Maybe he's just frustrated. So go back, pause, think about this for yourself, reflect for a moment, think of an event, cancer, and how it activates your inner nerves, your thoughts, your emotions, and how it affects you physically or your patients. Here again to remember Sarah and how to do that. And once you learn that skill, you realize that all these hints you have are expressions of underlying needs. So if we make Sarah go away and contemplate of what's in her need box, look at the physical body. She clearly tells you, I can't sleep. That's something you can do about it. These needs are concrete invitations to solve her problem. If we look at emotions, she's irritable, so we know she's in a stress condition. She otherwise sounds like a nice lady. Can she sign up for a program that helps her relax her nerves? Acupuncture might work. There are plenty of complementary methods. There's a literature article that's attached to the talk about what you can do with your mind and your body to help it not be in a fight and flight state, but in a rest and restore state. If you remember the slide I showed you earlier, where on the left side you saw on the left side you saw fight and flight, and on the right side you see rest and restore. This nervous system that seems to have a life of its own needs to be calibrated. And there are numerous things you can do with patients to help them. Thinking often is a problem. People have very intense thought content. It cycles, it stresses out their body. You can practice thought replacement with them. Not something that's easy, but easier than saying, I'm sorry you're depressed, I'm sorry you're anxious, let me go send you to an expert. You as a provider, whoever you are, oncologist, a nurse practitioner, a psychiatric nurse, a physical therapist. This is a basic concept you can use on everybody, even in your interactions with your coworker. So what are the first steps of mastery? This is a new paradigm, so you might be puzzled at applying it. You even heard me use the words depression and anxiety a lot, even though I'm advocating not to. It's part of our culture. But whatever you do when you approach a patient, first take a deep breath no matter what. Breath is the strongest natural inducer of the parasympathetic tone. That's the balancing part of this nervous system that I told you about, the autonomic nervous system. And whatever you see in the patient, there's a good chance it's related to stress. It's not always true. Sometimes they have other problems. But when you look at the slide at the beginning, 40% of people of that article I told you by Dr. Carlson report distress of some kind. So you're casting a much wider net. And then you narrow it down. You be more specific. You ask specific questions that give you clues. Do they need something for their emotions? Do they have a practical problem? Do they want to see a chaplain? Maybe none of us are really helpful, and what they need is a spiritual leader. One thing I urge you is to stay away from mental health categories. It's very easy to throw out these words. Oh, he has OCD. Oh, he has PTSD. Don't. Look at a person as being on a continuum of human existence that covers a very, very broad range. And your job as a provider is to find out where people are on the continuum and then take steps accordingly. And when you go after these hints, so if someone says, oh, I have no energy, you don't have to address their thinking. You can maybe help them sign up for a Qigong class or an exercise class, or have someone come to the house and, read a book with them. Something that we know will activate people and get them out of their fatigue. And another point I want to make, sometimes people are excited about discovering what their needs are. They might want more closeness with their partner. They realize having cancer puts them in a place where they want more meaning, but their partner might be exhausted and can't get more closeness. They might, in fact, need more distance. So can you teach your patient to analyze that, to identify it, and then if they can't get more closeness, realize that their partner is exhausted and needs more distance? And accommodate that, negotiate, be realistic about what you can and cannot do. But if you take one thing from the slideshow is cancer is not a mental health disorder issue, it is a distress issue. Thank you very much for listening, watching, and have a good day or a good evening.